Assalamualaikum warahmatullahi taala wabarakatuh. Thank you, Madam Chairperson, for the very kind introduction. So, my research is entitled as above, Seroprevalence of Strongyloides infection among patients with diabetes mellitus in Hospital Pakar USM. I would like to thank Dr. Haris, my MPhil student, for preparing this slide for me. Okay. So as for the introduction, we know that the overall prevalence of diabetic in adult more than 18 years old is 18.3%, which is equivalent to 3.9 million. And for adult more than 30 years old is 24.1%, which is equivalent to 5.1 million. So this is taken from the CPG Diabetic 2020, and I believe this CPG has not been updated yet. So we have got a figure from 6 years before. And for pre-diabetic, we have 23.6%. So it's about 5 million of them. Table 1.2, you can see the prevalence of the overall diabetes by the age group. And if you can notice, the highest prevalence of 40 to 43% is ranging in the older age of 60 to 74 years. So what is the seroprevalence of Strongyloides? So maybe I would like to introduce the worm first. As you all know, you all may be familiar with Ascaris, but this one is another nematode named Strongyloides stercoralis. So it is an intestinal nematode. It has the form of adult worm and also the larva. So for the prevalence, it actually depends on the country, method that you use, and also patient population. For direct stool smear here, the prevalence for Cambodia is 21 to 44%. For Laos is 41%. This is because they use additional stool smear plus PCR. For Thailand, 1.4 to 9.5, and in Malaysia, it's about very low, 0.05% by microscopy. So what about the seroprevalence? It can be detected by ELISA or ICT method. So in a national population based in Cambodia, the seroprevalence is 45%. In hospital patient Vietnam, 7.4%. In Malaysia, we have three figures. One is cancer patient here, 4.2%. This is figure 2014. In inmate prison, 8.8%. And indigenous community Sarawak, 11%. So comparison of the diagnostic method, we have many diagnostic methods for strongyloidiasis, but the current that we use in our lab is direct stool smear. The sensitivity is quite low, 21 to 30%. And specificity is 100%. It means that if you see the larva, it is specific and diagnostic. But for serology, the sensitivity is higher, 85 to 97%, way better than the stool smear. But the specificity is lower, slightly lower, 82 to 100%. Why? It is because if you detect the antibody, it can be acute or chronic infection or previous exposure. Okay, so I would like to stress on the strongyloides, what it can cause harms to the patient. It can have 4 clinical syndrome, acute chronic hyperinfection syndrome, as well as disseminated strongyloidiasis. So for acute, patient can present with skin disease or larva occurrence, respiratory symptom, dry cough, and so on, and also GI symptom, abdominal pain, diarrhea, and so on. And if the patient survived the infection, I think it's okay. But most of the patient, it went to the chronic strongyloidiasis, whereby there is actually an auto-infection occurring inside the body. But most of the patient is asymptomatic. But somehow Somehow, if the patient had some form of immunosuppression, for example, corticosteroid therapy, transplant, patient malignancy or malnutrition, the patient, the strongyloides can have accelerated auto-infection cycle, whereby the retiform larva can go into the filariform larva, and the cycle will continue inside the patient, giving rise to hyperinfection syndrome. So in this hyperinfection syndrome, you have many larvae in your GI tract as well as the pulmonary. And in advanced cases, the larva can go outside that and go more into the cardiac, brain, kidney, as well as giving rise to more severe infection. And on top of that, as a complication, also patient can have secondary bacterial or fungal infection. So what are the problem statement for this research? Actually, the relationship between strongyloides infection and diabetes is still unclear. Why? Because in some study, the association between positive serology and diabetes has been done in some countries, like for example, Brazil. So they find out that the positive test results is high in diabetic patient. So in Brazil, they have 23%. In Australia, they have 25%. But in another study, the presence of strongyloides infection appear to be associated with a significantly reduced risk of diabetes. So this is done in Australia. So the justification for the second statement is that when you have acute worm infection, it will excite Th2 immune response and increase in the eosinophil as well as IgE antibody. So with this, the worm will be killed. But somehow increase in the eosinophil will cause infiltration in the adipose tissue, and it will activate the activated macrophage. So this macrophage will secrete the cytokine, especially interleukin-10, so which will increase the Th2 response of the body. So what happened? Th2 response of the body will increase the insulin sensitivity. So when the insulin sensitivity is increased, the risk of getting diabetes will be low. So having said that, the bidirectional relationship between strongyloides and also diabetic patient is presented in this table. So what I have said to you just now is illustrated in panel B. So it usually occur when you have strongyloides first, but at that time you did not have the diabetes. But for panel A, if you are diabetic patient and after that you have strongyloides infection, so what will happen? So in diabetic patient, it will increase the susceptibility to infection. I think everybody know, kan? When you got diabetic, the impact neutrophil function will be happen, and also the macrophage function will be weak. It is due to your hyperglycemic status, and this will increase the susceptibility to infection, not only for larva, it's also for other things, for example, melioidosis and so on. So secondly, in strongyloides, it will cause accelerated autoinfection because patient with diabetes has diabetic enteropathy and slow gut motility. So it will retain the larva longer in your body, and this larva will retain the Th2 immune blunting in a chronic infection. So this will cause hyperinfection syndrome in diabetic patient. And third point is that if diabetic patient, for example, you got diabetic and suddenly you got cancer, or you got diabetic and suddenly you got SLE. So this patient will be subjected to corticosteroid treatment. So what happened? Corticosteroid treatment in the evidence of undetected infection, it will cause hyperinfection syndrome. And if the patient is not fortunate, the patient will undergo to the disseminated infection, whereby this larva can go to the lung, CNS, and liver, and cause increase in the mortality of the diabetic patient. So having said that, the problem statement for this study is actually we need to determine the seroprevalence of Strongyloides infection in diabetic patient and to improve early detection of strongyloidiasis, and thus we can do risk stratification for this diabetic patient to prevent hyperinfection and disseminated strongyloidiasis. And this data will support better clinical management and also screening policy for this strongyloidiasis. So having said that, the objective is we have two. One is to determine the seroprevalence, and number two is to describe and compare the demography, clinical characteristic, and lab profile of diabetic patient with strongyloides infection. So for the methodology, it is actually a cross-sectional study. We do it in KPP from January to December 2023. Written consent were obtained from all patients participated in this study. We calculate sample size for both objective, and the largest sample size is 326. In this study, we take residual serum samples from routine HbA1c that was sent to the chemical pathology lab, and that same serum sample we test for strongyloides antibody using SS rapid kit. And the demographic data, glycemic status, and also clinical feature and lab parameters are obtained in the checklist. So from this flow chart, actually we obtain the sample frame from KPP and we complete the checklist, and we take the HbA1c results and leftover serum sample from chemical pathology lab. And actually, regardless of HbA1c status, all serum sample were tested for the strongyloides antibody. And positive patient will be notified, and treated negative patient will be notified to the KPP doctor. And the data will be analyzed using the SPSS version 22. So for the material, this is the SS rapid kit. It is an ICT method, just like the COVID test that you do the RTK COVID test. We use serum sample to put into the cassette, and the test will be read in 15 minutes. So this kit is high sensitivity and specificity. The sensitivity is 96% and specificity is 91%. The kit has been proven for testing in quite a wide multiple countries, for example, in Switzerland, Thailand, Iran, as well as in Malaysia. And this ICT is suitable for routine screening and also for public health program. Okay, this is the diagrammatic presentation of the kit. And I would like to draw your attention to the results. Yeah, we have a semi-quantitative results. When you test the patient, it can be negative, positive, +1, +2, +3, or +4. It depends on the strength of the antibody. So now we go on to the results. Altogether, we have 107 positive out of 329 participants. So this gives rise to 23.5% positive. Okay. And actually, we have done quite an extensive analysis for this data, but somehow, if you can see, most of the data are not significant. But we are satisfied with the analysis, because in this few table we compare in between seropositive and negative. And after that, we compare in between the seropositive, whether the HbA1c is less or HbA1c is more. So we redo one more analysis after this. So in this table, if you can see male and female patient, according to the control and uncontrolled HbA1c, we found that for both gender and age, there is no significant association between glycemic control and also seropositivity of rapid test, 0.4, 0.7, 0.9, 0.5. Okay, again for the renal profile, lipid profile, and liver function test, again, for seropositive as well as seronegative patient, we did not find any evidence of renal impairment associated with seropositivity. So again, no significant p-value. For lipid profile, also the same as well as for liver function test. Okay, for table 3.5, we look at the demography of the seropositive patient and seronegative patient. Also, we did not find any significant value in between patient age less than 60 and patient more than 60. So in between age and seropositivity also did not give any significant p-value. But if you can see, more patient with age more than 60 have more positive serology results. Okay, for male also same, but in this study we found out that a little bit more male patient had positive serology results compared to the female. Also for the place, residence of the patient, Kota Baru and neighboring, in between positive serology, more patient with positive serology resides in KB and neighboring district, as well as for CKD, HbA1c, fasting, and also clinical symptom. Yeah. Okay. For clinical symptom, only in this study we have one symptomatic patient. Yeah? One symptomatic patient. This patient is positive for strongyloides, and at the same time, patient got diarrhea. But other patient with positive serology, all patient did not have any symptom that we have discussed just now. Okay, this table, we compare, if you notice, we compare, this is among the seropositive patient. Okay, this is among seropositive patient only, but we compare in between HbA1c less than 6.5, more than 6.5. Again, only serum sodium is found to be significant in between HbA1c less than 6.5 and HbA1c more than 6.5. But for other parameter, lipid profile, liver function test, the difference is not statistically significant. Okay. Also, for the distribution of sociodemographic in seropositive patients, so this is all among the seropositive patient, we can see a little bit of the difference. Like I said just now, more than 60, more patient here, male, KB, and so on. CKD status, yes, but the difference is not statistically significant. The only significant results is for the fasting blood glucose. So in this study, we found out that the fasting blood sugar level was significantly associated with the glycemic status of the patient. Okay. And again, in this statistical analysis, we also found that patients are asymptomatic. More patients are asymptomatic. And among patient yang the one that is symptomatic, it is actually more than HbA1c is more than 6.5. So you can see maybe if your diabetes is so uncontrolled, maybe you will have a symptomatic symptoms of the Strongyloides stercoralis infection. So for the discussion, we have only 2 slides left. There is a high seroprevalence of Strongyloides stercoralis in our diabetic patient, which is 32%. Uncontrolled diabetic, HbA1c more than 6.5 was more common among seropositive individual across the age and gender strata, but however, there is no significant independent association was demonstrated. And this finding actually suggests that other environmental exposure and host factor may be exert a stronger influence as compared to the glycemic status alone in the seropositivity of strongyloidiasis. Clinically, the predominant asymptomatic infection in a poorly controlled diabetic is concerning due to the potential progression to hyperinfection syndrome. Okay, an elevated HbA1c was associated with low serum sodium, likely reflecting the metabolic effect of the hypoglycemia. And maybe it is also contributed to the chronic parasitic infection. So lastly, chronic hyperglycemia impact the neutrophil function, cell-mediated immunity, and cytokine response. So this immune dysregulation may cause chronic strongyloidiasis and increase the risk of hyperinfection in diabetic patients, especially if the patient are subjected to corticosteroid exposure or treatment. So for conclusion, poor glycemic control was frequently observed among seropositive individuals, but it was not independently associated with infection status, suggesting a multifactorial risk in this infection. And since in this research, all variable is not significant for seropositive antibody, I think it is important to screen a diabetic patient for strongyloidiasis antibody, especially if the patient is going for any corticosteroid or immunosuppressive therapy. Okay, lastly, this study was supported by my lab grant from Ministry of Higher Education. Thank you.